Hey everybody, this is Miss Story, and I'm here to discuss with you respiratory dysfunction in the pediatric population. This PowerPoint comes from Chapter 21 in your Wong's Essentials of Pediatric Nursing book. This is PowerPoint 1 of 2, as this covers a lot of material. A respiratory tract infection is classified by which part of the respiratory tract it affects. The upper respiratory tract includes the nasal cavity, the pharynx, and the larynx, and the lower respiratory tract includes the trachea, the primary bronchi, and the lungs. Now, usually an infection may start in one of these and then spread further down the respiratory tract as it follows along that mucosal lining. The etiology and course of these infections are influenced by a number of factors. Firstly, infectious agents. Most pediatric respiratory infections are caused by viruses. These can include RSV, rhinovirus, influenza virus, and adenovirus. Bacterial infections of the respiratory tract in children are usually caused by group A beta hemolytic streptococci, staph, bordetella pertussis, and pneumococci. The age of the children impacts the likelihood of infection in a number of ways. Infants up until about 3 to 6 months of age are usually covered by maternal antibodies and are less likely to get infections. However, at 3 to 6 months of age, that's when the maternal antibodies begin to wean and they begin to form their own antibodies. So we'll see an uptick in infections at that age. That usually continues till about 5 years old. So it's very common in young children to see frequent viral infections, especially if they are in daycare settings. Size. The smaller diameter in the airway of young children means that they're more affected by edema in the mucous membranes and increased secretion production in those membranes. So you're more likely to see a narrowing. Organisms are able to pass through the respiratory tract more quickly due to a shortened length. So a child may start with an upper respiratory infection and very quickly develop into a lower respiratory infection. Also in the ears, they have shorter and more open eustachian tubes in infants and young children, and that leads to an increase in middle ear infections. Resistance. Conditions that lower resistance and predispose children to infections include asthma, preterm birth, allergies, a history of RSV, or cystic fibrosis. Most often, respiratory pathogens tend to spread more commonly in the winter and the spring months. For example, I'm sure you're all aware that flu season runs from October through May, and then RSV season usually includes the winter and the early spring. This is a list of just general signs and symptoms you'll see with respiratory tract infections in children. This population can be especially challenging because they're either nonverbal or they're unable to describe how they're feeling. So you'll have to rely on nonverbal cues to differentiate some of these signs and symptoms. The first one we're going to start with is a fever. A fever is often the first sign of infection. Children, especially age about 6 months to 3 to 5 years, tend to run a much higher fever than you're going to see in adults. They can get up to 103 to 105 with even a mild infection. A fever will change a child's behavior. They'll be more irritable. They may be lethargic. They may have a decreased appetite. They're going to be tachycardic, tachypnic, and they'll be at risk for dehydration. You also want to watch for febrile seizures in children, especially if there's been a giant increase or decrease in the fever in a short amount of time. Poor feeding is often a direct result of the infection or a result of abdominal pain or difficulty swallowing, especially if they have a sore throat or if they're bottle fed and they have nasal blockage or discharge, then they're going to be unable to swallow, frequent coughing. So there are several things that go into the poor feeding. Some other signs are vomiting, diarrhea, abdominal pain, the nasal drainage or blockage, and you're going to want to look for the color of the drainage, the frequency, the consistency, and that's going to tell you how far along we are into the infection or what the causes may be. Cough is a common feature of an infection, and the different kinds of cough that we'll learn about later will clue you in onto what's going on. Respiratory sounds, such as, like we said, a cough, hoarseness, grunting, stridor. On auscultation, you can hear wheezing, crackles, or absence of breath sounds. Sore throat, and there are several causes of a sore throat. It can either be viral or it can be bacterial. It can also be from nasal drainage. And lastly, they can also have meningeal signs without an infection of the meninges, including a headache or pain and stiffness around the back of the head. This usually occurs with an abrupt onset of fever. In assessing the respiratory function in a pediatric patient, there are several components that we're going to look at. This video here does a really good job of demonstrating a lot of them, so you may want to listen to this and then watch that video. These children here actually have an RSV infection. But in pediatric patients, it's often hard to get a good auscultation. They're usually crying, they're moving, same thing with the O2 sat. So you want to make sure that you assess everything that's going on to get a good picture, because you may not be able to assess them as easily as you would an adult. But you want to pay attention to the pattern of respirations. Is it tachypnic? Is it depressed? Is it normal? Are they having work of breathing? Do they have nasal flaring or head bobbing? And you'll see these in this video. Do they have retractions? Or is it depressed and the depth of the respirations is shallow? And then infectious symptoms. You want to look to see, do they have a fever? Do they have nasal drainage? What color is it? How much is it? You can get a sample of that with a bulb syringe. If you're not able to get them to cough any up, you can put that in the nares. Then when they do cough it up, you want to look at that sputum as well and see what color it is. You can test that as well. If it's bacterial, you can have a sputum culture to see what's causing the illness. A description of the cough. As we go through this lesson, you'll see that a lot of these dysfunctions have very particular sounding coughs. Same thing with respirations. So is the cough productive? Is it dry? Is it brassy or croupy sounding? What makes it worse? Does it worsen with activity or does it worsen at night? What makes it better? Does cold air or mist make it better? Does rest make it better? And then the sounds on respirations, is there audible wheezing or stridor? Of course, the auscultations, you heard crackles in the lungs, wheezing. Cyanosis, you'll see cyanosis around the mouth frequently if they're not getting enough oxygen. Chest pain in older children may tell you that they have chest pain either from the shortness of breath or heaviness or tightness or from frequent coughing. And then we already talked about the sputum, and then bad breath can often be caused by things like tonsillitis. The upper airway infections can cause a change in the odor of the breath. Nursing care management for respiratory dysfunction in the pediatric patient is twofold. Not only are you caring for the patient, but you're also caring for the parent. A lot of times the parents are scared, stressed, and they feel like they've lost control of the situation and they don't know what to do. So you really want to pay attention to both the child and the parent and provide holistic care. Part of that care includes easing respiratory efforts, such as humidified oxygen, helping the child to stay in the position that's most comfortable, promoting comfort, letting them receive the treatments in the parent's lap, letting them have comfort items in the room, prevent spread of infection. So you want to teach good hygiene to both the patient and the parents, monitor who visits the child, and keeping them away from anyone who's been sick. Reduce body temperature. If they're running a fever, that's going to increase irritability, that's going to cause them to be tachypnic and tachycardic, and increase their respiration. So you want to pay attention to that, and give them Tylenol or Motrin if they're over 6 months, but never give them aspirin, because that can cause the Ray's syndrome. Promote hydration. Hydration is important because firstly, when they're sick, they have that decreased appetite, so they're not wanting to take in, and they run the risk of dehydration. And also, hydration helps to break up any mucus secretions so that they can cough it up. Observe the patient for decline or respiratory distress, such as a change, whether they are calm and they become extremely irritable, or they're irritable and become lethargic. Retractions, nasal flaring, head bobbing. Then you want to provide nutrition. A lot of these illnesses are going to decrease their desire to want to eat, so you want to make sure that they're getting adequate nutritional intake. And lastly, you want to provide family support and home care. You want to provide a lot of education to these parents. The more that they are educated about what's going on, the more empowered they will feel and the more calm and at ease. Now we're going to move on to focusing on the upper respiratory tract infections, and we'll look a little closer at some of these, but your book covers acute viral nasopharyngitis, acute infectious pharyngitis, tonsillitis, influenza, otitis media, and infectious mono. Acute infectious pharyngitis is a bacterial infection, most common caused by group A beta hemolytic streptococcus, or strep throat. It's the most common cause of acute infectious pharyngitis. Of course, because it is bacterial, we're going to treat that with antibiotics, usually penicillin. In the presence of a penicillin allergy, then you may turn to a macrolide like azithromycin. Untreated strep throat can lead to rheumatic fever or acute glomerulonephritis. Rheumatic fever is an inflammatory disease of the heart, joints, and the central nervous system, and glomerulonephritis is an acute kidney infection. Strep throat causes symptoms such as sore throat, headache, fever, abdominal pain. The tonsils in the back of the throat or pharynx are going to be inflamed. They may be covered in exudate or those pus pockets that we're used to seeing with strep throat. The tongue may be red and swollen. They may have bad breath or bad taste in their mouth. Children may develop a sandpaper-like rash called scarlet fever from the bacteria, and the throat may be mildly sore to severely sore. Some kids I've seen, they didn't complain of a sore throat. The first symptom we picked up on was the rash. The cervical lymph nodes are going to be swollen. Again, the throat pain can be mild to severe, and it may make swallowing difficult. So we're going to be looking at their intake with this. This is diagnosed with a throat swab. Now, the throat swabs aren't always the most reliable, so if the child is highly symptomatic but they swab negative, then a throat culture may be obtained. If that's also negative, then we're probably looking at a viral pharyngitis. Some children may be carriers of this group A, beta hemolytic strep, and test positive in the absence of an acute strep throat infection. So they may have viral infections, and every time they're swabbed, they're going to test positive. Nursing care for strep throat. Of course, first we're going to perform that throat swab. We're going to give education on proper antibiotic administration. Like I said, making sure that you complete that course of antibiotics so we don't create a super infection. And then suggest ways to provide pain relief and comfort for the child. You can put cold or warm compresses on the neck, gargle salt water, warm salt water. They can give ibuprofen or Tylenol for pain. You want to encourage fluid intake because, like we said, the swallowing is painful. They can try ice chips, cool liquid, or popsicles. Are usually a winner, and that'll also soothe that sore throat. Now, children are infectious for a full 24 hours after they start the antibiotics. After that, they can go back to daycare if their fever's broken. If their symptoms are not any better after 24 to 48 hours, then we're going to want to take a look at that and make sure that we're treating it correctly because of the side effects that can be caused, um, the rheumatic fever. And then you want to instruct the parents to throw away those toothbrushes after they've been taking the antibiotics for 24 hours because they can have that strep bacteria on there and we don't want to reinfect the children. The tonsils are a mass of lymphoid tissue in the back of the throat. Tonsils in children are usually larger than those in adults. They believe that's because children tend to have more frequent upper respiratory infections, so they need that extra help from the lymphoid system. Tonsillitis is, of course, an inflammation and an infection of the tonsils. You usually see that go along with pharyngitis. It can either be viral or bacterial. Of course, viral is usually self-limiting, and bacterial will need to be treated with antibiotics. One of the things you worry about with strep throat is protecting that airway. As the tonsils swell, it can close off that airway. You may notice the child have difficulty sleeping, eating, and they may snore at night. Other than antibiotics for bacterial tonsillitis, some of the same treatment goes along with that as it did with strep throat as far as comfort, warm saltwater gargles, the ice or warm packs to the throat, ibuprofen or Tylenol, that kind of thing. However, sometimes treatment of tonsillitis or frequent reoccurring tonsillitis requires a tonsillectomy. There are a few things that may warrant a tonsillectomy and adenoidectomy. First, if they have recurrent throat infections or tonsillitis, and the frequency that warrants surgery will be determined by the ENT and by the insurance. Sleep disordered breathing, are they waking up frequently or snoring loudly at night? That could indicate that there's an obstruction from those tonsils. And also they could have an emergent tonsillectomy, and that's if there is severe airway obstruction observed in an acute case of tonsillitis and they're afraid that that airway is going to be completely obstructed. I was 18 when I had an emergent tonsillectomy. It was my first case of tonsillitis, but it was so sudden and so severe that they had those tonsils removed by the end of the day. The adenoids, which you can see from this picture, are in the back of the throat as well, but more so behind the nasal cavity. They're removed when the child has had frequent episodes of rhinorrhea or if they have sleep disturbances with nasal obstruction or frequent ear infections. So if that nasal cavity is frequently infected and just plugged up. And again, the frequency that warrants surgery is going to depend on the doctor and the insurance. These are usually an outpatient surgery as long as everything goes well, which means that you're going to need to provide some good discharge teaching so that when they get home, they're not confused and unsure of what to do. So the things you're going to want them to look out for post-op, number one is bleeding. Bleeding is going to be evident if they're frequently swallowing or clearing their throat, if they're nauseous, or if they're, of course, if they're vomiting blood. And then they're also going to want to monitor for signs of dehydration because with that throat being sore, they're not going to want to drink as frequently as they would normally. So make sure they're having good wet diapers, good urine output, and then monitor for signs of airway obstruction. This is rare, but in case there's a lot of edema at that surgical site. Some ways you can teach them to reduce pain and discomfort. They can use an ice collar. They can give them that Tylenol and ibuprofen, or if there's a prescription pain medication prescribed, make sure to give that in the beginning around the clock to stay on top of that pain. Now, I've heard that children tend to recover pretty quickly from tonsil surgery. When I had mine out at 18, it was miserable and very painful. You also want to encourage cool water, ice chips, popsicles. That can reduce the swelling and the pain and also keep up that hydration. Once they're able to tolerate soft foods, you want to avoid anything that is acidic, like citrus, because that can irritate the site. It also says you may want to avoid things like milk, ice cream, or pudding because that may cause the child to clear the throat, which can initiate bleeding. Usually ice cream is one of the first things they're looking forward to afterwards, but I said that's not good. So um, they also want to avoid anything that may cause them to cough frequently, clear the throat, blow their nose. You want to avoid frequent suctioning or drinking from a straw. And that's a big one um, because that can irritate the surgery site, that can cause bleeding. Another big one, so we're avoiding the straw, we're watching for frequent swallowing, and you want to stay away from red liquids because if they do start bleeding, you don't want any confusion between what is blood and what is the red liquid they drank. So just avoid that. It makes things a little easier. You want to provide good support before, during, and after for the children and the parents because a lot of times this will be their first surgery. It's a scary experience, and they're going to need you to encourage and support them through this process. Don't forget that when you're assessing pain in children, they're often not able to understand the numeric pain scale. For children, we use the Wong-Baker Faces Pain Rating Scale, and that way they can look at the faces and it helps them describe how they're feeling. For infants who are too young to use the FACES pain rating scale, you'll have to assess your patient for subtle clues. If the child or the infant is excessively fussy or irritable, if they're not able to sleep well, or if they're not eating well, these all may be signs of pain. Influenza is a virus that is spread by direct contact and droplet precautions. It's most common during the winter months and it's often seen in young children. Symptoms of the flu may include dry mouth and the nasal mucosa, a dry cough, hoarseness, flushed face, body aches, fever, and chills. Tamiflu can be prescribed to lessen the flu symptoms if the children is over a year old. That must be taken within 2 days of the onset of symptoms. And one of the major side effects of Tamiflu is mental disturbances such as nightmares or hallucinations. So watch out for any changes in personality when taking the Tamiflu. Children over 6 months of age are eligible to receive the flu shot or the flu vaccine, and that's given yearly. Prolonged fever or fever during early recovery is a sign that the child has developed a secondary bacterial infection, such as a pneumonia or otitis media or an ear infection. Acute otitis media is an inflammation of the middle ear. It has a rapid onset of signs and symptoms, which include fever and ear pain. Often this child will have a viral infection first that has a lot of mucus backed up and build up, and the child may start to get a little better from their viral infection, then all of a sudden they're spiking a temp. And you want to look for an ear infection in those situations. Other symptoms may include they're pulling at their ears, uh, increased fussiness or irritability, especially when you lay them down. So they're going to have trouble sleeping. They're not going to want to eat because when they suck on that bottle, it's going to increase the pressure in that middle ear and cause more pain. And they may roll their head from side to side. Otitis media with effusion is when there's fluid in the middle ear without symptoms of an acute infection. Chronic otitis media can cause hearing loss and difficulty communicating because these children have ear infections all the time. It's going to decrease their ability to hear during a time when they need to be able to hear to develop their own verbal skills. So they may have communication or verbal delays. Some of them even require speech therapy. Secondhand smoke increases the risk of persistent ear infections. Some other predisposing factors may be upper respiratory infections or allergic rhinitis, like we talked about. If they go to a daycare, so they're around a bunch of germs, or if you prop the bottle up, you'll see this sometimes parents will have the child in a carrier and then prop the bottle up so that they don't have to hold it for them, and that can cause an ear infection, so we don't want to prop the bottle. Otitis media is diagnosed by looking at the tympanic membrane in the ear. The membrane will show a bulging or a fullness, and it'll be yellow or reddened. These infections are treated with oral antibiotics such as amoxicillin or cephalosporins like Ceftonor. If needed, an incision into the eardrum called a meningotomy may be needed to drain that infected middle ear fluid. More often, you'll see tube placements in the ear or an adenoidectomy used to treat recurrent chronic otitis media. Now, those tubes are not permanent, and as the child grows, those tubes may fall out, and they may have a reoccurrence of the ear infections. The Prevnar vaccine has been shown to lessen the frequency of ear infections. Nursing objectives or interventions during this is to relieve the pain, to facilitate any drainage that may be coming out of the ear, prevent any complications, and educate the family and provide emotional support. Often these children are excessively fussy and irritable. They're not eating, they're not sleeping, so the family and the child are really going to need emotional support during this time. Also, you need to teach prevention of ear infections, such as not propping the bottle, and then proper antibiotic use. So I know we say this every time we talk about antibiotics, but you want to make sure that they take every dose and don't just stop when the child starts to feel better. Okay, if you will, take a moment and review what you've learned so far. Okay, now we're going to talk about the croup syndromes. These affect the larynx, trachea, and bronchi. They produce symptoms like hoarseness, a barking or brassy cough, inspiratory stridor, and respiratory distress from swelling. They were originally caused by H. influenzae type B, but that's now been vaccinated against by the Hib vaccine, so now most cases are viral. Okay, the first croup syndrome we're going to talk about is acute epiglottitis. The epiglottis is a hinged piece of cartilage that attaches on the inside of the thyroid cartilage. It closes the entryway to the trachea during swallowing, and it opens to allow respiration. Epiglottitis is a medical emergency where the epiglottis becomes inflamed and swells, causing a risk of airway obstruction. As you can see in the bottom right-hand corner of this slide, what a normal epiglottis looks like, and then what happens when it becomes inflamed. You can see that airway is pretty much non-existent. This is most commonly seen in children ages 2 to 5, and the most common cause is the H. influenzae type B that we talked about, and that can be prevented with the Hib vaccine. That Hib vaccine is given in 3 to 4 doses, and it's administered at 2 months, 4 months, 6 months, and then at 12 to 15 months. It can also be caused by other bacteria such as Streptococcus pneumoniae, etc. The 3 cardinal signs of this are an absence of a spontaneous cough, so this one does not have a cough, presence of drooling, and agitation. They're drooling because, of course, their airway is closed off, so they're not able to swallow that. You're also going to notice tachycardia. They're going to be restless because they're scared. They can't swallow. It's a very scary situation. There may be retractions as they're trying really hard to work to bring that air in. Of course, they're going to be more and more anxious. There's going to be inspiratory stridor, and that's that high-pitched whistling sound as they pull that air in through that tiny little hole. Do not use a tongue blade, oral thermometer, or obtain a throat culture with this infection. Do not stick anything in their mouth. Why? Because this could cause a spasm, and that'll just completely block off that airway. You also never want to leave this patient alone because they're at risk for a sudden airway obstruction. So you want to make sure someone's always in the room watching them. You want to keep emergency equipment at the bedside and have trained staff ready and available for possible intubation. To monitor the temperature, of course, we're not going to take that orally, but you can check it rectally, tympanically, or temporally. You want to keep this child calm, because when they start to cry or become very anxious, that increases this chance of airway obstruction. So you want to let the child stay with the parent, um, at all possible. They can sit on their lap during treatments. Don't restrain the child. Never leave them alone. Try to provide a calm environment. Uh, do things that prevent the child from crying. Allow the child to be in a comfortable position to breathe. That's going to be the tripod position, and you'll see that in a little bit, where they lean forward. They may rest on their hands. They're sitting up, and they've got their chin turned upward, and that's trying to open up that airway as much as possible. Do not lay them supine, because that impedes the respiratory effort. It closes off that airway. Keep the child nothing by mouth until this can be fixed. Um, give medications per the doctor order. You might give IV fluids, antibiotics, medication for the fever, and definitely corticosteroids. That's going to decrease that swelling. They would usually give steroids to kind of cut that down. They also may give cool mist humidification. Um, and like I said, make sure you keep that trach tray ready. All right, this is that tripod position we talked about. It's known as a hallmark sign of acute epiglottitis. Children will assume this position to try to keep that airway open as much as possible. So let them stay in this position or whatever they find most comfortable in, because we want to protect that airway as much as possible. And again, do not lay them flat. Acute laryngotracheobronchitis is the most common croup syndrome. When we say croup, this is usually what we're talking about. It primarily affects children from 6 months to 3 years old, and is usually caused by a virus like rhinovirus or influenza A or B. This starts out with an upper respiratory infection that spreads to these adjoining structures. This often starts slow with a low-grade fever, and then develops into this barky, brassy cough. The swelling in the airway narrows it and produces that signature stridor sound as they breathe in and inhale through that narrowed space. The child with LTB usually develops the classic barking or seal-like cough and acute stridor after several days of rhinitis. Hoarseness may also be seen. This usually occurs at night in the fall and winter. It can be diagnosed just by these hallmark symptoms we talked about. However, if they do an x-ray, you can see in this picture, they'll see the classic steeple sign where the swelling has caused the trachea and the larynx to make a steeple shape. The main treatment goal is to maintain the airway and adequate respiratory exchange. You want to teach the parent the signs of respiratory distress like tachypnea, tachycardia, restlessness, anxiety, nasal flaring, head bobbing, retractions. The treatments include cool mist, like a ride in the car with the windows down, opening the freezer. They also will use racemic epi, which is nebulized epinephrine if that's severe. The epinephrine will cause vasoconstriction and reduce that swelling. They can also give oral steroids to treat croup. Like we talked about in epiglottitis, you want to allow the child to remain calm. They can stay in the parent's lap during treatments. Then you want to, like I said, teach the signs and symptoms of respiratory distress. In my line of work at the daycare, we used to have a child who had a stridorous condition, and we would use what we had, which was a shower. So we'd go in that room and let it steam up, and he'd breathe in the steam. But now they're seeing that cool mist actually helps more than the warm mist. We are working our way down the respiratory tract, and now we're going to talk about infections of the lower airways, including bronchiolitis and bronchitis. Bronchiolitis is one of the most common infections of the lungs in children and infants. It's usually seen in a newborn to about 2 years old. The most common cause of bronchiolitis is RSV. which is an extremely contagious virus that's spread through airborne droplets in direct contact with mucus. If you work in pediatrics at all, unfortunately, you're going to see RSV. Now, RSV, anybody can get this at any age. Adults, it usually just presents as a common cold, but it can be much more severe in children and especially in infants because their airways are smaller. This is because RSV causes inflammation of the airway, and then it also causes increased mucus secretion in the bronchioles, so that obstructs the flow of air. Symptoms of RSV can include labored respirations, poor feeding, cough, tachypnea, retractions, flaring of the nares, emphysema, increased nasal mucus, wheezing, and possibly fever. Treatment involves oxygen therapy to keep their SATs above 90%. Bronchodilators is needed. You're going to want to do suctioning. You can do the bulb suctioning of the nasopharynx, and then adequate fluid intake. That lower airway involvement, like we said, causes wheezing, retractions, crackles in the lungs, dyspnea, tachypnea, and diminished breath sounds. This can be diagnosed with a nose swab. Nursing interventions with the RSV, you want to use humidified air. Keep the room warm but not overheated. If the air is too dry, a cool mist humidifier can moisten that air and help ease that congestion and coughing. Be sure to keep the humidifier clean to prevent the growth of bacteria or molds. But that humidified oxygen can help to decrease or to thin those secretions so that children can tolerate it better. And then non-humidified oxygen, if they're getting it via nasal cannula, can dry out their nares and can even cause nosebleeds. You want to encourage fluid intake, so keep a supply of cool water at the bedside. You may want to offer warm fluids such as soup that can help loosen those thickened secretions. Ice pops might be soothing if an infant needs to continue to breastfeed or bottle feed. Like we talked about earlier, if they're have those secretions in their nose and they're stopped up, you want to use that bulb suction to keep their nares clean so that they can drink their bottle or breastfeed. You want to encourage good hygiene habits. Teach your children the importance of hand washing. Don't share eating utensils. Label each person's cup because, like I said, this is very contagious. Give medications as prescribed and encourage compliance. In high-risk children, they do have a medication to prevent this. Those that are with chronic lung disease, like babies with asthma or cystic fibrosis or congenital heart disease or premature babies, it's called Synagis, I believe, and it's an IM injection once each month during those high-risk months, October to March. Now, infants that get RSV, depending on their age, if they're closer to newborn, they may automatically get admitted. As they get a little older, then we'll just observe them very closely. Unfortunately, RSV can cause scarring in the lungs and increase their risk of developing asthma-like conditions later on in life. One of the risks of RSV is pneumonia. Pneumonia can occur either as a primary disease or as a complication of another illness. This is when that infection moves deep down in the lungs and into the alveoli where the oxygen and carbon dioxide exchange takes place. Pneumonia is usually classified based on their cause, such as viral or bacteria, community-acquired or hospital-acquired. Viral pneumonias are often caused by viruses such as RSV, influenza, and adenovirus. Most of the time, children can be treated at home with rest, hydration, and medications as needed, like antibiotics or for fever. Nursing management would include oxygen as needed, fluids, and antibiotics if it's bacterial pneumonia. You also want to frequently assess their respiratory status, hydration, and level of activity. You may need to suction if needed. And don't administer cough suppressants unless you actually have to, like if they're coughing all night, not getting any sleep. Cough suppressants of course, are going to suppress that cough, but we want children to cough up that mucus to clear the lungs and improve their respirations. A lot of times, pneumonia can be a result of parents giving cough suppressants to children with viral infections. Um, like RSV, they have that extra mucus and they're not coughing it up, so it's settling down in the lungs. Now, if they're coughing all night and they're not getting any sleep at all, then you may, if the doctor okays it, prescribes it, can administer small amounts of cough suppressants through the night. But otherwise, we really want them coughing that stuff up. All right, it's time to test your knowledge again. Okay, if you will meet us on PowerPoint number 2 for the rest of this, we're going to split this up because that's been a very content-heavy lecture.